As we get the presentation started, I thank you so much, Dr. Chan. It's such a pleasure to be here today. Can everyone hear me at the back of the hall? Excellent. So I'm one of two pediatric rheumatologists at Scarborough Health Network. Dr. Elisa Rackless and myself are dedicated to our rheumatology patients. And yes, children get arthritis too. And I've been asked to present a general topic. I'll be speaking on pediatric limp. And it's a huge topic. I have 15 minutes. And I hope to give you three major pearls on it. I've entitled the talk, Leaping Lizard, the Lamentable Limp, just to keep everyone awake and be in touch with my artistic mind. And I have no financial conflicts that are relevant. And my three objectives for the next 15 minutes are to review first common presentations of pediatric limp. What are you going to see in your general office or in your emergency department? Secondly, red flags of pediatric limp, when to worry and what diagnoses to think about. And finally, as a pediatric rheumatologist, how do rheumatic diseases present? And what are some of the other signs that give you a clue to think of autoimmune disease or inflammatory problems? 15 minutes, here we go, seatbelts on. Okay, so common presentations of pediatric limp, the number one thing you'll likely see in your general office is growing pains. And growing pains occur in 1 in 5 children in Canada. They generally present in young children at 4 or 5 years of age and can go on for 5 to 10 years. It's often inherited, and there's a family history of similar problems, and children present with lower extremity pain. It can be anywhere from the hip down, unilateral, bilateral, it can change, and often it's significant pain in the evenings or in the middle of the night, waking up crying in pain. But the key is the next day, they're perfectly normal, they're functionally doing great, and their exam is unremarkable. That's important. So you don't need to investigate these kids, you just reassure the family. And if there's anything unusual, the exam is abnormal, they're having daytime symptoms, then you have to start thinking of other things. The second major category is traumatic causes. In that is mechanical pain or overuse, and there's a laundry list here that you can all understand. Any injury to the muscle, tendon, ligament can give a limp and pain. I wanted to mention common overuse and recurrent injuries in the pre-adolescent, like patellofemoral syndrome and Osgood-Schlatter, which present with anterior knee pain and swelling of the patellar tendon or the tibial tuberosity. Seaver's disease presents in younger children with heel pain and is also a kind of overuse injury. Their exam, they'll have pain on squeezing the heel, and it usually happens with activity. The x-rays are normal to rule out any kind of bony abnormality, and basically it's rest. You can consider orthotics, ice and Advil if it's quite severe, and it generally self-resolves. I want to mention overuse injuries because we see children now being pushed to play lots of competitive sports, and so you're going to see children, for example, an 8-year-old gymnast doing 14 hours of gymnastics a week. That kind of situation can lead to recurrent lower extremity pain and other injuries, so you need to think about it. From the talks I've attended from sports medicine physicians, the general rule of thumb is an hour per age per week. So if a child's 8 hours a week is the max. I think that's a nice pearl. Hypermobility, so children who are bendy, kids that have bilateral pes planus or flat feet, or those who are double jointed, they tend to get more joint pains. So it's important to, that's a whole other talk by itself, but looking for signs of hypermobility on exam, I would recommend reading a little bit about that. Those children tend to get more pains. They tend to stress and strain the joint beyond normal, and so they tend to get more injuries. How we manage that is maintaining physical activity, but mixing up the sport, so they're not doing the same repetitive movement over and over again and causing pain. Fracture and skiffies, you know that. So the last category of common causes of limp is that of infection or post-infection. So during an acute illness, let's say influenza, a child often can limp, and the classic presentation is that of calf pain and myositis, and it can be quite significant where they have a challenge walking. We manage that with anti-inflammatories like ibuprofen. And post-infectious phenomenon are really quite typical. I see that a lot as a consult. So a child can have any kind of infection, a common cold, a bladder infection, diarrhea, even impetigo, and a week to 4 weeks later they may present with joint swelling or muscle pain and limp. We generally manage that with ibuprofen or acetaminophen, and it generally self-resolves within a week up to 4 weeks. If it's persistent, then you start needing to think about other things, doing some blood work, and giving us a call. What about red flags associated with LIMP? So I want to keep it really simple. These are the things you need to consider a more serious cause. So a child with inability to weight bear. Even with ibuprofen or acetaminophen, they cannot weight bear. That is a red flag, a situation where you would actually send them to emerge. So things like fractures, septic arthritis of the hip, or a malignancy can present with things like that. Secondly, fever at the time of LIMP. So as I mentioned, acute infection can do that, so you need to consider what's going on with the child. But when a child has a fever and they're having difficulty walking, you need to start thinking a little harder, do I need to do some investigations or not? Pain out of keeping with the physical exam findings. This is really important. So if you have a child that's limping and complaining of knee pain and is crying to the point that you're having difficulty walking, but there's not much to see on exam, that's really important. That could be a sign of malignancy. And finally, constitutional symptoms, persistent fevers, night sweats, meaning not just sweating from the neck up, not a big deal, but actually drenching the pajamas, drenching the sheets. This is true night sweats, having weight loss. These kind of situations, you think of red flags. And finally, rheumatic diseases. How do autoimmune and inflammatory problems present? And it's a laundry list, and this is a whole talk by itself, but the principles are many of these conditions present with things beyond LIMP. So for example, Henoch-Schönlein purpura or HSP, they have purpura. They have palpable bruising of their lower extremity. They may have abdominal pain and kidney involvement. There's clues of something more. Kawasaki disease presents in a child with persistent fevers for 5 days, and often they have rashes, conjunctivitis, and other symptoms. IBD-associated arthritis, these children may have signs of colitis, diarrhea, bloody diarrhea, weight loss, fevers, or just an anemia and persistent symptoms of LIMP. Juvenile arthritis is the one that's a bit of an exception. Juvenile arthritis may not present with anything beyond joint involvement, except some of those kids do get inflammation in the eye with no symptoms. So it's important if you see a child who has a persistent joint inflammation, let's say a swollen ankle that's not going away after 4 weeks or 6 weeks, consider a diagnosis of juvenile arthritis, particularly a young child under 5. It's not what you would expect, but that's the typical age of presentation. And make sure to get a routine eye exam and think about anterior uveitis that can present with no symptoms, but a proper ophthalmology or optometry check can find inflammation in the eye. So I decided I like to do my talks and have interaction, and we don't really have microphones around, but I ask you to shout it out. I want to see if you can help spot the diagnosis. These are mostly autoimmune, inflammatory, or rheumatic diseases where the picture can give you a clue of the diagnosis. So shout it out. This child's been unwell, having fevers for several days. It could be many diagnoses, but what would you think of? Kawasaki disease. So I start easy. Perfect. So it's typical. So these children, the classic presentation is in a young child, persistent fever for at least 5 days, with non-purulent conjunctivitis. Often they have oral changes, red lips, and swollen glands, rashes, and they need hospitalization and IVIG treatment. Anybody know what that is? Shout it out. Correct. So this is actually severe chronic anterior uveitis. It can be isolated on its own, but it can be associated with a child with juvenile arthritis. And essentially what happens is there's inflammation in the anterior chamber of the eye. They have no symptoms, and they're slowly going blind. So this child has cataracts from chronic inflammation, and you can see what's called a stellate pupil, star-shaped pupil, caused by chronic scarring in the anterior chamber. Perfect. You guys are too smart. Okay, so this is a child with systemic lupus erythematosus. So she's presenting with the classic malar rash. It's almost pathognomonic of systemic lupus. The differential includes juvenile dermatomyositis. And typically it presents in girls, though it can present in males. And often these children also have fevers, alopecia, joint pain that's quite severe. Sometimes they can have irregular periods. And the clue is in their blood work often. They have cytopenias, and this is important to diagnose early. It's getting harder now. HSP? No. This is not HSP. HSP usually presents with purpura of the lower extremity. You can have some involvement of the upper extremity, but not usually. Yes, perfect. So, thank you. So she mentioned juvenile. We call it juvenile idiopathic arthritis now. So this is a subtype of juvenile arthritis called systemic arthritis. There's actually 7 subtypes of juvenile arthritis. And this subtype are associated with recurrent fevers. The fevers are quotidian, so it's like a clock. They present at 10 a.m. and 5 p.m. every day at the same time. And associated with the fever, you get this evanescent rash that comes and goes, and they often have arthritis associated with it. You can't answer any more questions. She knows all the answers. Okay, so this is the heliotrope rash that you see with juvenile dermatomyositis. A heliotrope is a kind of purplish flower. That's why they give it this name, because you get this purplish hue of the eyelids. It's pathognomonic of juvenile dermatomyositis, so they get rashes, they get arthritis, and they have muscle weakness involving the proximal muscles, the upper arms, the upper legs. The other rashes that these children can get are called Gottrin's papules on your left there. So those are flesh-colored papules of the extensor surfaces. And then if you notice in the right picture, the nail folds where the cuticle is quite inflamed. This is a kind of vasculopathy or vasculitis. So they have inflammation of the capillaries. And so you can see this erythema. And if you look carefully with an otoscope and mucogel, you can actually see inflammation or bleeding in the small blood vessels. She knows the answer. Any ideas? Perfect. So this, you guys remember your medical school days. Excellent. So this is a child with juvenile scleroderma. This is extremely rare. They present with fibrosis of the skin, causing tightening of the skin. This child, when he tries to smile, he cannot form a proper smile because the skin is tightening of the face. Similarly, the fingers have tightening of the tips, and often they have Raynaud's. They have those nail fold changes, and they can also have arthritis. Excellent. So now we're going to end with 3 cases to kind of give an overview of what I've tried to teach. These are based on real children. I've just simplified the cases for teaching purposes. So this first child is a 7-year-old Southeast Asian female, previously well, who presents with recurrent anterior knee pain associated with Limp. The pains are generally in the evenings, and there are some times where she's wakening at night with pain up to once a week for the last year. What's the most likely diagnosis? Oh, the exam is normal. This is growing pains, exactly. So we're not going to investigate, and we're going to reassure this family. The second child is that of a 2-year-old male of Afro-Caribbean descent with a past medical history of asthma. He came to see me with cough for a couple of weeks, and he was on Ventolin and Flovent puffers, but he'd also been limping for 2 weeks as well, and no treatment for that was given. When I examined him, his vitals were stable and he was afebrile. He had sparse wheezing. But when I examined his lower extremity, it was really quite painful to walk. And he was crying and was having difficulty ambulating. And he seemed to be in pain in his right ankle, but there wasn't much to see on exam. There was no swelling, no redness, no changes. So someone mentioned sickle cell. That's an excellent thought. How would you manage this child? Exactly. So there's several possible diagnoses: sickle cell, trauma, unlikely without the swelling, malignancy. There's a list of things. So the important thing is this child warrants management, investigation. And so I did a basic X-ray, and it was normal. And I did a basic CBC differential with an ESR-CRP, because for me as a rheumatologist, the ESR and CRP help me to know if I need to worry about bad things. And the higher the inflammatory markers, the more concerned I am. And this child actually had pancytopenia with just a 2-week history of Limp. And the inflammatory markers were really high, and there were predominantly blasts. So his diagnosis was acute lymphoblastic leukemia. And he was seen urgently at Sick Kids, and he did amazing. He's well. It's been 6 years, and he's doing fantastic. So the final case is that of an 18-month-old male, previously well, who presents with left knee pain and swelling. He has no history of previous trauma or infection. And when you look really closely at the knee, it's actually swollen. And the best way to see this is when the child is standing, there's blunting of the medial border of the patella, so you don't see it well, so there's actually an effusion there. And when you measure the quadricep, there's muscle wasting with at least 1 centimeter thinning of the quadricep on the left leg versus the right. And finally, there's a leg length discrepancy where the left leg is 2 centimeters longer than the right. And he's smiling and happy. So what's the most likely diagnosis in this child? There's a differential, but what's the most likely diagnosis? Shout it out, anyone. Post-infectious, okay. And JRA? Perfect. This child actually has juvenile idiopathic arthritis. And going back, the clue is the chronic changes. So though the parent has just noticed the swelling over the last week or two, the muscle wasting, the leg length discrepancy tell me that the child's had inflammation of that knee at least 2 or 3 months. So that's the clue. So in a growing child, inflammation near the growth plate stimulates bone growth, which causes the leg length. So that was the clue, the age, the well-appearing child, they don't complain. This is juvenile arthritis. You do the basic blood work, CBC, differential, ESR, CRP. If you can, do the ANA, rheumatoid factor, to help me subtype the arthritis and get the eyes checked. Okay? So that's it, guys. So I'll finish off with my final notes. So my final thoughts, I hope that in this whirlwind, you now know the common causes of Limp in childhood: growing pains, traumatic causes, overuse injuries, and infection or post-infectious causes. I hope you can recognize red flags of Limp: fever, inability to weight bear, constitutional symptoms. And finally, I hope now you know some of the classic presentations of juvenile arthritis and other rheumatic disease. And I open the floor to questions.